Great, thank you. Thanks everyone for sharing your lunchtime with me today, and Happy New Year. I am Suann Gaydos. I'm a practicing dental hygienist. I received my tobacco treatment specialist certification through the Mayo Clinic in 2010. I practiced for many years as a private practice dental hygienist, and now I'm a professor within the WVU School of Dentistry, where I teach dental hygiene and dental students part-time, and the other part of my time, I direct the Certified Tobacco Treatment Training Program, which is housed in the School of Dentistry. And interestingly, out of the 27 accredited programs in the world, we're the only one that's housed in a dental school. So that makes it kind of interesting. And it is not, oh, there we go. Now it's letting me change them. So today we're going to quickly review the health risks that are associated with tobacco use disorder. We're going to discuss why it's so hard for people to quit using tobacco products. And we're going to review evidence-based tobacco strategies to improve quit attempts of your patients that are trying to stop using tobacco products. So, as I'm sure you're all aware, tobacco use disorder is a chronic disease. It kills 480,000 people throughout the United States each year. It causes, actually, smoking, as you can see with the slide on the far left, causes cancer everywhere throughout the body due to the carcinogens and toxic metals and chemicals that are in tobacco products. And it can lead from have several chronic diseases as an end result. Some of those being cardiovascular disease, cerebrovascular disease, respiratory disease. And as a dental hygienist, I feel I need to explain why the tobacco treatment training program is housed in a school of dentistry. It's because nicotine increases pro-inflammatory mediators and delays our immune response to any pathogens. And in the mouth, the periodontal pathogens do not get killed by our immune systems that are delayed during tobacco use. And so there is a really increased risk of periodontitis. It also really dries the mouth out. So there's an increased risk for decay. It can also lead to fractures of bones and decreased fertility. Even being exposed to secondhand smoke causes severe chronic illness. And vaping, although it's considered less harmful than smoking, it has its own set of risks. It dries the mouth out. The flavoring agents have ingredients that can scar the air sacs in the lung. It has a great increase in cardiovascular disease, stroke, and hypertension. And because of the increased exposure to the carcinogens that are in vaping e-liquid, it can also lead to cancers. More research needs to come out on this for the various types to be published. If nicotine is inhaled prior and used regularly prior to the age of 25, when the prefrontal cortex is fully developed, it increases anxiety, compulsive behaviors, causes mood disturbances, and impairs the adolescent's ability to pay attention, retain facts, and apply information. Due to alterations in the levels of dopamine and also serotonin in the brain, those who vape are twice as likely to be diagnosed with depression. And if tobacco is used early, it can also increase the risk of addiction to other substances of abuse because nicotine increases the high of drugs of abuse and also is used to help with the withdrawal symptoms from those. Because tobacco use temporarily lowers stress and is used as a coping mechanism for depression, it can have an end result of major depressive or bipolar disorders, schizophrenia, paranoia, or dysfunctional responses in social or occupational settings. And it was already mentioned how tobacco use is linked with lifelong addictions. Sadly, West Virginia still ranks the highest in tobacco use rates. You can see where our adult and youth smokers double the national smoking rate. We are anywhere from 2 to 4 times the smokeless tobacco rate, and vaping has an especially high prevalence among teens. And with a survey that was done in 2024, the Monitoring the Future survey, it showed that there was an increase of youth vaping from 15% in 2020, almost tripled to 29% in 24. So vaping has become very popular among youth. To make tobacco cessation more important for your professional field, 40 to 45% of cigarettes are consumed by those with mental disorders. 70 to 80% of schizophrenic population smoke, and 50 to 70% of people with bipolar disorder smoke. Why is it so hard to quit? Well, when nicotine is inhaled, it only takes it about 10 seconds to cross the blood-brain barrier to reach the nicotinic acetylcholine receptors in the brain. When nicotine reaches these receptors, it mimics acetylcholine, and several neurotransmitters are released. You can see those on the right-hand side, and these lead to heightened alertness, improved mood, improved cognitive performance, and it reduces anxiety. The quick action of nicotine makes it a potent psychoactive agent and reinforces its continued use. With repeated use of nicotine, the receptors in the brain become desensitized, and to compensate, more receptors appear, and they're screaming for nicotine to bind to them. The altered balance of these neurotransmitters dysregulates systems associated with stress, mood, and cognitive function. As neuroadaptation progresses, more nicotine is needed to achieve the same desired effect. The brain needs nicotine to function normally. Without nicotine, withdrawal symptoms occur. These usually appear within 4 hours of the last use of nicotine, and they're very uncomfortable. Minor issues make people become very irritated, frustrated, or show their anger. They have intense cravings for whatever tobacco product they're using. They feel depressed, anxious, and restless. They have a hard time thinking. Their heads hurt. They don't sleep well, and they use food to try to improve their mood. So there's about an average of 10 pounds of weight gain with tobacco cessation. The desire to quit is quite high at 70%, but sadly, only about 44% of these make a quit attempt, most likely due to the physical, mental, and social aspects that are barriers to abstinence. Only about 3 to 6% of unaided or cold turkey quit attempts are successful or result in cessation. So you have to remember that nicotine addiction is a complex brain disease, changing the brain's chemistry, structure, and function. There are effective treatments available that help people regain control and improve their brain health. So hopefully I won't run out of time, and we'll get to those effective treatments. People with mental illness are vulnerable, as nicotine relieves symptoms of depression and schizophrenia. But multiple studies do show improved mental health with tobacco cessation. So if you only take one thing away from this noon presentation, I want you to be aware and make your patients aware that smoking can lead to a higher clearance of some medications, potentially reducing their effectiveness. Tobacco products contain polycyclic aromatic hydrocarbons that release enzymes that metabolize or eliminate drugs quicker. The listed antipsychotics and antidepressants on the left-hand side are cytochrome P40A1A2 and cytochrome P40-2C19 isoforms. So if you're wondering if medications that you have your patients on, you can do a search in a drug review to see if they may need these enzymes for metabolism. But you should make your patients well aware that smoking interacts with metabolism of drugs if they're on the medications that are listed. You should consider each patient's smoking status when you're making your treatment plans, and you should evaluate the need of increasing these drugs' dosages with your patients that smoke. On the right-hand side are some common drugs that are also affected if you have patients on these medications. So you can see that even a patient with type 1 diabetes, if they make a quit attempt, they could result in some pretty scary hypoglycemic episodes if their insulin is not adjusted. And caffeine is also highly dependent on CP1A2 from its metabolism. Smokers require up to 4 times the amount of caffeine than non-smokers. So it's very important to make people aware when they're making a quit attempt. So the feelings that they have with too much caffeine, like anxiety, insomnia, headaches, and increased heart rate, aren't linked with their quit attempt. So the easiest way, rather than telling them not to drink as much coffee, is to suggest that they brew a half decaf, half caffeine coffee brew so that they can continue to have the same cups of coffee, but it'll just have less caffeine so that they don't feel that high caffeine effect. Another really important aspect to take away from today's presentation is the amount of nicotine that's in each type of tobacco product. This is really important when we're trying to dose nicotine replacement therapy correctly. So a cigarette has about 1 milligram of nicotine per cigarette, and a pack of cigarette contains 20 cigarettes. So if your patient is smoking a pack a day, then they're exposing themselves to 20 milligrams of nicotine. This is going to be important in a couple slides when we're talking about the various doses associated with the nicotine patch. Cigars have a surprising high amount of nicotine. A large cigar, which usually takes an hour to 2 hours to finish, has 20 milligrams of nicotine, so the same as a pack of cigarettes. Little sweetened cigarillos have about 3 milligrams of nicotine, and little cigars are the same as cigarettes with around 1 milligram. Smokeless tobacco is loaded with nicotine. 1 can has 80 milligrams, which is equal to 4 packs of cigarettes. So if somebody is using a can a week, we'll divide 80 by 7 and get about 11 milligrams, which is equal to about a half pack of cigarettes. I personally have family members who have had heart attacks due to using smokeless tobacco, and it was my brother. He was using a can a day at the time. He has successfully quit, thank goodness, but it was the massive heart attack that forced that quit attempt. Now, vape products are another whole challenging product, trying to find the amount of nicotine that's in them because their ingredients are not regulated. So the contents and the level of nicotine vary per brand and per product. It's really hard also to find the amount of nicotine in them when you're doing a search. So this slide is very helpful. Juul pods, which are not as popular anymore due to some regulation on them, contain about 41.3 milligrams of nicotine per pod. Only about 68% of this nicotine is truly absorbed, so that makes a Juul pod contain about 28 milligrams of nicotine. More popular now are these disposable bars that are out. Some popular brands are like Goose, Elf, Puff Bars, Capri's, Geek Bars. They have a lot of nicotine in them also, about 50 milligram. So when 68% of this is absorbed, it makes their nicotine content about 34 milligrams. And then mods are types of vape products that you can place your own e-cigarette liquid or other agents into them, and they hold more. So about 90 milligrams of nicotine are in these refillable mods, and about 68% of that is absorbed, equaling about 61 milligrams of nicotine. So you can see the high amount of nicotine in these vape products, and it should really scare you and make you really want this regulation on vape products to go through more consistently. Before we start talking about nicotine replacement therapy, I want you to be aware of nicotine pouches and know that they are not the same as nicotine replacement therapies. They're really popular right now among college students. I've talked with a lot that are truly addicted to them and not really realizing what it's doing to their bodies. So they're little sachets filled with synthetic nicotine salts, and they have a lot of nicotine in them. The FDA has also said that they're not truly tobacco products because they don't truly have tobacco leaves in them. So they are not being regulated, and they are really highly addictive because the synthetic nicotine gets to the brain receptors very quickly, unlike nicotine replacement therapy, which takes a while. Also, take a deep breath and know that it's proven that evidence-based treatment works well with people with mental illness. And if their condition is stable, it will not worsen their quit attempt. You also may find once they quit that medication that you have prescribed to them is working more effectively. When we say the words evidence-based tobacco treatment, we're talking about the use of behavioral counseling and tobacco cessation pharmacotherapy together. When this is done, it doubles abstinence rates. So remember, when a quit attempt is tried unaided, only about 3 to 6% are able to truly quit. And you're the experts with the first part of this, the counseling part. When somebody is ambivalent about their quit attempt, using motivational interviewing can pull from them the reasons why it's important for them to quit. And also using cognitive behavioral therapy can help them identify what triggers them to smoke and come up with alternative ways to handle those situations. Some things that have worked well for me are if somebody says it's the hand and mouth of smoking or vaping that they miss, cinnamon sticks that you can buy in the grocery store in the spice section gives them something to hold and take to their mouth. There's also anxiety breathing devices that they wear like necklaces that help with that hand to mouth, what they're used to. Exercise helps release dopamine into the body, and just having them doodle or keep something in their hand to keep them busy can also help with the cognitive behavioral part of quitting. Then there are 4 nicotine replacement therapies that we're going to talk about. These help reduce the nicotine withdrawal symptoms, and there are 2 prescribed medications. So varenicline is now only offered as generic, but it's Chantix. It reduces the favorable effects of smoking, and bupropion, which you should be well aware of, is an antidepressant, which keeps dopamine and norepinephrine in their system, leading to feeling happy. So evidence or FDA approved pharmacotherapy for smoking, and it can be used off-label for smokeless and vaping, are listed here. There are 6 of them. 3 are over the counter and 3 require a prescription. The nicotine patch is over the counter. It provides a consistent long level of nicotine that takes about 6 to 8 hours for the nicotine to peak. So it works better when you combine it with the 3 short release nicotine therapies that are listed below it, because this will get nicotine into their system much quicker in about 15 to 20 minutes, and will really manage the withdrawal when you combine a long-acting nicotine patch with the 3 short-acting that are listed. Bupropion, as you already are well aware of, is an antidepressant, and varenicline is a partial agonist to the nicotinic acetylcholine receptors, and it removes the reinforcing effects of nicotine. We're going to talk about each of these individually. Clicked it one too many times, sorry. So first, the nicotine patch comes in 3 steps. So 21 milligrams is step 1, 14 milligrams is step 2, and 7 milligrams is step 3. You want to base the patch that you prescribe on the nicotine that they are taking in every day. So going back and thinking about that slide that listed the amount of nicotine in each product is very important when you're dosing or recommending the patch. These patches are used for a total of 10 weeks. So if you have a patient that is using one pack of cigarettes a day, they're being exposed to about 20 milligrams of nicotine. So you would start with a 21 milligram patch. With the initial patch, they're going to place it anywhere between their waist to their shoulders in an area that is dry and doesn't have a lot of hair on it. They're going to place it and wear it for 24 hours and then remove it and place it in a different location for the first 4 to 6 weeks at that dose. Then they'll move down to the 14 milligram patch, move it every day to a different area of the body, and continue that for about 2 weeks. And then 7 milligrams will be used for the final 2 weeks. It's very common for the adhesive on these patch to cause minor skin irritation, which can easily be treated with over-the-counter hydrocortisone cream. And one of the common side effects from the nicotine patch is sleep disturbance. And if this is occurring, they can remove the patch at bedtime and then put the new one on in the morning. We're going to talk about the nicotine gum and lozenge on the same side because they're very similar in their dosage. They both come in 2 and 4 milligram options, and you decide which you're going to use based on the amount of time from waking to using. So if they can wait more than 30 minutes to use their tobacco product, you would start with the 2 milligram gum or lozenge. And if they need to smoke within 30 minutes of waking, then the 4 milligram would be appropriate. Now, these can be used as monotherapy, but it's quite difficult for people to adhere to this because at first they need to use the gum or the lozenge every 1 to 2 hours. And that is really hard for people to adhere to. Combining it with the nicotine patch, then the patch would keep the nicotine in their system and they would just use the gum or the lozenge as needed for their cravings or withdrawal. Also, the acidic environments in the mouth will affect the absorption of the nicotine. So they're advised not to eat or drink for 15 minutes before using. One way I've cheated and gotten around this is by having patients put a teaspoon of baking soda in a cup of warm water and swish their mouth with that to make it more alkaline, and then the nicotine will absorb quickly. Common side effects from the gum and the lozenge are mouth or throat irritation. It can cause hiccups and upset stomach. They're used different than normal gum or normal lozenges. So with the gum, they need to chew it for 15 to 30 chews before a peppery or tingly feeling appears in their mouth, and then they park it between their cheek and their gum. They do not continue to chew it like normal gum. If they do this, the nicotine's not going to be absorbed, and they're going to feel nauseous or lightheaded, maybe even dizzy. So they park it between their cheek and their gum and leave it there until that tingling feeling fades, and then they can chew for a couple more seconds and stick it in another area of their mouth. It's very effective if used correctly. Slightly more effective than the gum is the nicotine lozenge. It's wet with saliva and placed between the cheek and the gum, between the cheek and the gum. And it can be left there. If the person makes the mistake of chewing it and swallowing it, then the nicotine is not going to be absorbed, and they'll have the same result of feeling nauseous, lightheaded, or dizzy. It can be moved throughout the time that it's in the mouth, which is usually about 30 minutes for both of these for the nicotine to be effective. That doesn't affect it, but it just needs to stay in the vestibule for the nicotine to be absorbed. The nasal spray is highly effective. So the pro of it is that it works faster than the gum or the lozenge. It takes it anywhere from 5 to 10 minutes to reach its peak, where the gum and the lozenge take 15 to 20 minutes. But the negative is that it is really expensive, and it requires a prescription. So people can't just walk into the drugstore and purchase this highly effective nasal spray. I hate to admit it, it's not my favorite because of the side effects that occur. The cost is about $11 a day for if you view the national rate. So they have to spray 2 sprays, 1 in each nostril. Each spray delivers about 0.5 milligrams of nicotine. They use this initially for 6 to 8 weeks with about 8 doses a day. The maximum dose is 5 doses an hour or 40 doses a day. They use it a little different than other nasal sprays, which makes it very important to tell them how to use it. So they don't spray it and sniff it, inhale it into their lungs. They need to spray it and let it absorb in through the nasal mucosa. So there's going to be running out of their nose. It can make their eyes tear up. It can cause throat and nasal irritation and can cause sneezing and coughing. It's not attractive. So not my favorite out of all of the options that are available, but it is the fastest for the nicotine replacement therapy. Some precautions that we need to be aware of for all of the nicotine replacement therapy is that it needs to be delayed if the individual has had a heart attack within the 2 weeks, unless you're a cardiologist and you're working directly with them, or if they have underlying arrhythmias or chest pain that have not been treated. All of these pharmacotherapies have not been tested with pregnant or adolescents under the age of 18 very well. So there's always precaution with pregnant females and adolescents. For the gum, if they have trouble chewing, pain with their TMJ with chewing, then you should choose the lozenge or the nasal spray. If they have ischemia or a dermatologic condition, the patch can make this worse. And if they have polyps, nasal polyps, or severe reactive airway disease, then the nasal spray should be avoided. Moving on to bupropion, SR. So it does still have a black box warning on it, as you're probably very aware of, for increased risk of suicidality in young adults. And it is started 1 week before their quit date. And you start with 150 milligrams 1 time a day for the first 3 days. And then the rest of the 12 weeks, is 150 milligrams twice a day, and you want to make sure that there is 8 hours between these doses. Common side effects from bupropion are insomnia, dry mouth, and nausea. If they're having changes in their mood, especially if it's suicidal thoughts, you want them to know that they can stop it immediately and notify you for further guidance. This, out of all of the pharmacotherapy, is the only one that has a true contraindication, and that is if they have epilepsy, they should not be using it. You can choose something else. Or if they have situations that increase their seizure threshold, like bulimia, anorexia, head injury, or if they've suddenly stopped alcohol or sedatives. Also, if you have them on a monoamine oxidase inhibitor, they need to stop taking this 14 days prior to starting the bupropion. Also, if they have liver impairment, that may affect the drug's use. So you'll need to have a conversation with their specialist to see if bupropion can be used with them. Varenicline is my personal favorite. I'll just let you know that because it's very easy to take and it's very efficient. If we would select just one of the pharmacotherapies of the 6, varenicline has the highest efficacy, and right with that would be combining the nicotine patch with the faster acting nicotine replacement therapies. So with varenicline, it is also a little pricey. It costs the same, about $11 every single day. But no, if your patients have insurance, all insurances cover all 6 of the FDA pharmacotherapies and counseling at 100% if they've reached their deductible. So with varenicline, it is a partial agonist to the nicotine acetylcholine receptors, and it keeps dopamine stable and blocks nicotine's strong effects. It can reduce both cravings and withdrawal symptoms by preventing the dip in dopamine, offering a steadier, moderate release that eases their transition off of nicotine. Studies show potential improvement in their cognitive function and managing mood disorders like Alzheimer's disease and with schizophrenia. So varenicline may be highly effective for your patients with schizophrenia. With this, like bupropion, you want to start it 1 week before their quit attempt to get it titrated up to the full dose. They're going to start 1 week before the quit date, take 0.5 milligrams in the morning for the first 3 days. Then day 4 to 7, they'll take 5 milligrams twice a day. Should probably go back 1 slide. And then weeks 2 through 12, they're going to take 1 milligram twice a day, making their total dose 2 milligrams a day. Common side effects are nausea and sleep disorders, so it's important to let your patients know to take varenicline with a full glass of water and with food. And if they have kidney impairment, where they clear less than 30 milligrams per minute, then the dose may be reduced in half, and they'll need to have discussions with their specialists for the appropriate dosing for them. So our varenicline has been, and bupropion were both highly studied with a really large study called the Eagles trial with over 8,000 participants, and it showed that the neuropsychic risks associated with both varenicline and bupropion were very low. It actually resulted in the black box warning being removed from varenicline. And like I already said earlier, varenicline is the most effective monotherapy. And in this large study, it was more effective than the placebo, the nicotine patch, and bupropion. So you can feel safe prescribing medications, to smokers that have mental illness, as long as they're made aware of the potential risks and that they are being monitored for any adverse effect. So as stated a little earlier, used alone, if they're going to select just one pharmacotherapy, then place them on varenicline. It has the highest efficacy. And when you combine the nicotine patch with the quicker acting gum, lozenge, or nasal spray, then dual NRT is equally as effective. Some of the evidence-based tips that I want you to remind you of from this presentation is that you need to make your patients that are smoking aware of how it's negatively affecting their overall health and their mental health. Please try to encourage a quit attempt with everyone that you work with, and I hope that you're all asking if they are using tobacco products. Use counseling and pharmacotherapy together. And know that your mental health medications that were listed on the one slide may require adjustments with their tobacco cessation attempts. And it is really hard to quit. So be prepared for them to be finished at one point with their tobacco product, and then they may come back a year later and be smoking or vaping again. It usually takes most people about 6 quit attempts. I want you to be aware of the program that I direct. It is an asynchronous program, which means it's all online and it's self-paced. It requires the minimum of an associate degree to participate. It provides 24 AMA credits or 24 internal medicine maintenance of certification points. It costs $750 to register. Right now, I do have some funding to cover a few more waivers that if you apply. So if you would be interested in taking the 24-hour online program, you can email me directly at mgaydos@hsc.wvu.edu to get more information, or you can scan this QR code to get more information about the online training. I hope you're still awake. Thank you. Are there any questions? I was not watching the chat at all, so sorry.
Thank you, Suann. I appreciate you coming today. Shameless plug, but it's really a fabulous course. My original course I took that was similar kind of really changed my practice and my style and was incredibly meaningful to me as a provider, especially as someone who had felt fairly useless trying to help tobacco prior to the course. And it really was a phenomenal experience, even when I took it originally. So,
and
thanks
Dr.
so much
Swagger is one of our presenters in the program and the reason why I'm here today. Any questions about any of the topics that were brought up? If not, I'll share something that happened